Again, to jump straight back in and continue reading from the article Psychiatry and the Presumption of Expertise, Flipping Coins in the Courtroom from 1974 by Bruce Innes and Thomas Litwack, digging into the state of psychiatry prior to the publication of the third edition of the Diagnostic and Statistical Manual of Mental Disorders, DSM-III, in 1980. We are starting back with Part 2, Reasons Why Psychiatric Judgments Are Unreliable and Invalid. Before discussing the specific reasons why psychiatric judgments are unreliable and invalid, it is necessary to recognize a more general problem. Individual psychiatrists are not given any opportunity to learn from their mistakes. Goldberg, for example, points out that clinicians rarely get feedback on the accuracy of their judgments. They may believe their judgments are reliable and valid, but they have no systematic way of testing that belief. For, unlike other specialties, psychiatry lacks adequate statistics and follow-ups, because psychiatrists have not seriously attempted to check on their methods and results in the way other medical doctors regard as their scientific duty. As a result, very little of what psychiatrists think they are able to do can be adequately validated. One psychiatrist has acknowledged that the absence of a self-corrective mechanism means that in many cases, the diagnosis of psychosis becomes almost a matter of chance. It is dependent on the training, experience, and personal philosophies of the psychiatrist who examines the person and the circumstances under which the person is examined. Although the specific reasons why psychiatric judgments and predictions are unreliable and invalid are varied, many of them can be grouped under 6 broad and occasionally overlapping headings. 1. Orientation and training. 2. Context. 3. Time. 4. Class and culture. 5. Personal bias. And 6. Inadequacy of the diagnostic system and ambiguity of psychiatric data. Finally, there are additional reasons for the inaccuracy of psychiatric predictions of dangerousness. Section A. Orientation and training. It has been suggested that psychiatrists are prone to diagnose mental illness and to perceive symptoms in ambiguous behavior because they are trained in medical school, and that it is safer to suspect illness and be wrong than to reject illness and be wrong. In other words, being a mental health professional may constitute a set to perceive mental illness. In addition, each school of psychiatry has a different view of what mental illness is, how it is caused, and how it should be treated. Substantial evidence suggests that psychiatric judgments are strongly influenced by these different schools of thought and training. Pasiminak, Dinitz, and Lefton, for example, inferred from their findings that, despite their protestation that their point of view is always the individual patient, clinicians in fact may be so committed to a particular school of psychiatric thought that the patient's diagnosis and treatment is largely predetermined. Clinicians may be selectively perceiving only those characteristics and attributes of their patients which are relevant to their own preconceived system of thought. As a consequence, they may be overlooking other patient characteristics which would be considered crucial by colleagues who are otherwise committed. Section B. Context. If upon entering a room one notices a book in a wastebasket, it is reasonable to assume it is not a valuable book. But seeing the same book in a locked bookcase gives rise to an entirely different opinion as to its value. Similarly, a person dressed in normal clothing and sitting in his living room creates one impression, while the same person dressed in a hospital robe and slippers and sitting on a bench in a hospital corridor creates a much different impression. It should therefore come as no surprise to learn that diagnosis is often influenced by the setting in which a person is observed, with inpatient settings disposing clinicians towards a diagnosis of psychosis. And the following is a particularly infamous study. In a study of pseudo-patients, 8 sane individuals, feigning one symptom of schizophrenia, were admitted to various mental hospitals with that diagnosis. Rosenhan found that even though immediately after admission, the pseudo-patients ceased displaying that symptom and behaved normally, once a person is designated abnormal, all of his other behaviors and characteristics are colored by that label. Indeed, that label is so powerful that many of the pseudo-patients' normal behaviors were overlooked entirely or profoundly misinterpreted. For example, when several of the pseudo-patients took notes of their experiences, that activity was noted in 3 of their records as an aspect of their pathological behavior. The purpose of Rosenhan's study was to determine whether the salient characteristics that lead to diagnoses reside in the patients themselves or in the environment and context in which observers find them. Although the pseudo-patients related absolutely normal life histories, Rosenhan found that diagnoses were in no way affected by the relative health of the circumstances of the pseudo-patient's life. Rather, the reverse occurred. The perception of his circumstances was shaped entirely by the diagnosis. Section C. Time. Since even normal people speak and behave differently one day to the next, it is no less natural for an allegedly mentally ill individual to appear agitated one day and composed the next. Consequently, the timing of a prospective patient's examination may substantially influence the diagnosis he or she is given. Edelman found that diagnostic impressions changed by a fourth interview therapy session about 20% of the time. He also noted that the typical procedure for establishing a diagnosis is a single, unstandardized interview, the results of which may be augmented by psychological testing. An implicit assumption of this procedure is that interviewee behavior has been adequately sampled in the allotted time span and that the interviewee is sufficiently motivated to reveal all pertinent information. Yet there are numerous studies which indicate that interviewee behavior is mediated by complex process variables, suggesting that such assumptions may not always be justified. In other words, even if a patient's behavior is consistent over time, different aspects of that behavior may be observed at different times. In addition, the limited amount of time usually available for a psychiatric evaluation may combine with psychiatrists set to perceive mental illness, thus resulting in overpredictions of disturbance. For example, when there is only limited time to examine a patient who is allegedly dangerous, the psychiatrist is likely to search for and find signs of dangerousness, such as aggressive fantasies. He is not nearly so apt, however, to be attentive to evidence of non-dangerousness, such as a history of good impulse control. Section D. Class and culture. There is considerable evidence that psychiatric judgments are strongly influenced by the socioeconomic backgrounds of the clinician and patient. Phillips and Dragons reviewed the literature from 1966 to 1969 and concluded, the influence of the client's socioeconomic class in facilitating the attribution of some and impeding the application of other nosological designations is particularly well documented. The findings converge in suggesting social distance as the mediating variable. Across socioeconomic or other subcultural lines, the middle-class diagnostician is prone to assign categories of severe psychopathology. In a controlled experiment, Lee and Timmerland found that the diagnoses of psychiatric residents were highly influenced by the imagined socioeconomic history of the patient and by the perceived diagnoses of other prestigious psychiatrists, independent of the clinical picture presented. A lower socioeconomic history biased diagnosis toward greater illness and poorer prognosis. Similarly, according to studies conducted by Ordway, clinicians may be influenced to conclude that lower socioeconomic class individuals are dangerous because such individuals are presumed to be impulsive and therefore more prone to violence. And of course, this is exactly the kind of socioeconomic bias you want in people who get to choose who is able to be free from incarceration and coerced treatment or not. Different cultural backgrounds may also have profound effects on clinicians' perceptions. Here the authors examine a study that compared American psychiatrists to British psychiatrists. British psychiatrists see different patterns of pathology and less pathology generally, especially less severe pathology. Section E. Personal bias. The factor which may most influence diagnosis is the clinician's own personality, value system, self-image, personal preferences, and attitudes. Raines and Rohrer, in their study of psychiatric predictions of combat officer candidate success, found that psychiatrists were predisposed to observe different personality traits in the same individual. Moreover, the various traits and symptoms observed were not valued equally by the different psychiatrists. The authors concluded that the psychiatry decision involves not only the psychiatrist's emotional problems and defenses, but also his entire value system and probably his self-image. This results in a greater sensitivity on the part of the psychiatrist for certain facets of the patient's personality structure and a greater perceptual distortion of other facets. Once perceived, correctly or distortedly, each item is subjected to the psychiatrist's value system. In a follow-up study, the same authors discovered that psychiatrists' observations and perceptions of their patients tend to reflect their own personality structures and problems. Gross and Grossman present evidence suggesting that the clinician's varying personal biases may account for the significant differences in their evaluation of ambiguous and emotionally charged case history data. They summarize their findings as follows. The more complex, ill-defined, ambiguous, unfamiliar, and uninformative the data, the more strongly the observer's set, focused attention, expectation, bias, and other intra-observer conditions come into play and influence his perception, judgment, and decision. The possibility exists that such judgments are less informative about the patient whom they are meant to describe than about the clinician who makes them. They may reveal the clinician's concepts of norms or his toleration of deviations compared to those of his peers, his clinical orientation and attitudes towards certain aspects of the patient's history, his clinical experience and interests, and perhaps even his own background and personality. Their conclusions are borne out by others. For instance, Dickey's, Simons, and Weisvogel demonstrate that the unconscious conflicts of clinicians often cause distortions in perception and misapprehension of the patient's true condition. And in the context of sanity hearings, Pugh found that the ultimate determinations are strongly influenced by the personal idiosyncrasies of the examining psychiatrist. Strupp found that therapists' perceptions of a patient presented in a film interview varied according to the therapist's experience and his attitude toward the patient. As an illustration of the latter factor, if for some reason the therapist disliked the patient, the result was often a poor prognostic evaluation. Braginski and Braginski suggested a possible context in which the psychiatrist might develop a dislike for a patient. Their studies showed that mental health professionals view patients who express radical political views as more disturbed than patients who voice the same psychiatric complaints but whose political views are more conventional. And naturally you get the following bias. They also discovered that voicing criticism of the mental health profession, whether from a radical or conservative perspective, may substantially increase a patient's psychopathology in the eyes of mental health professionals, while flattering the profession tends to decrease a patient's otherwise perceived symptomatology. This reminds me of the article The Tyranny of the Positive Attitude in America, Observation and Speculation by Barbara Held, which I have cited multiple times. Although it is reasonable to expect some degree of empathy from those closest to us, I believe that our family, friends, and colleagues cannot and should not be expected to have the same degree of empathy as a first-rate therapist. And the passage does apply as therapists are mental health professionals. Namely, it is not reasonable to seek from them professional, empathic skills. After all, they have their own personal needs and agendas when relating to us, whereas therapists, who also have their own personal needs and agendas in their own personal lives, must strive to keep those in check in the consultation room. In an ideal world, the mental health professional would indeed strive to keep their own personal needs and agendas in check. In reality, however, the mental health professional fails to do so, and in absolutely miserable fashion. Numerous other studies confirm that the clinician's personal values and attitudes strongly influence diagnosis and judgment. We have seen that idiosyncratic values and attitudes often influence psychiatric diagnoses and prognoses. Moreover, there is evidence that values and attitudes characteristic of psychiatrists as a group may influence other psychiatric judgments, such as the decision whether or not to release hospitalized patients. First, psychiatrists as a group may have little tolerance for deviant behavior and consequently may require a high standard of community adjustment. Second, psychiatrists as a group are likely to be paternalistic and therefore relatively insensitive to considerations of civil liberty. Third, psychiatrists may be susceptible to family pressures to commit. Fourth, psychiatrists may have a vested interest, for example, in the patient's continued participation in an experimental treatment program, which can only be fulfilled by the patient's continued confinement. Finally, psychiatrists may view poor adjustment to the hospital as a negative indicator of potential community adjustment, rather than as dissatisfaction with incarceration. Section F, the inadequacies of the diagnostic system and the ambiguity of psychiatric data. I'm only going to read the last part of this section. A significant ambiguity is raised by the Diagnostic Manual of the American Psychiatric Association, which presumably provides the basis for psychiatric diagnoses. In one part of the manual, psychiatrists are instructed to diagnose as psychotic only persons whose mental functioning is sufficiently impaired to interfere grossly with their capacity to meet the ordinary demands of life. That instruction, standing alone, would suggest to laymen and to psychiatrists that almost everyone diagnosed as psychotic would meet the criteria for involuntary commitment, mentally ill, and in need of care and treatment, in use in most states. In the next paragraph of the manual, however, psychiatrists are instructed that they may diagnose individuals as falling within the subcategories of psychosis, such as schizophrenic, paranoid, manic-depressive, even if the individuals are not in fact psychotic. Consequently, an assumption that an individual diagnosed as schizophrenic requires involuntary care and treatment often may be erroneous. psychiatrists would be the first to acknowledge that millions of persons who could be diagnosed as schizophrenic do not require hospitalization. Unless one realizes that a person may fall within a subcategory of psychosis without being in fact psychotic, the use of diagnoses such as schizophrenia is misleading and can prejudice the prospective patient's rights. Section G. Additional reasons why psychiatric predictions of dangerousness are invalid. While all the foregoing factors may also dispose psychiatrists to assess erroneously a patient's capacity for violence, there are additional, more particularized reasons why psychiatric predictions of dangerousness are of such limited validity. Unlike the task of formulating a diagnosis, psychiatrists are not even trained in the assessment or prediction of dangerousness. Medical schools do not offer courses in the prediction of dangerous behavior, nor are there textbooks explaining the method and criteria by which assessments are to be made. Rapport, for instance, conducted a thorough research of the literature and found no articles that could assist psychiatrists to any great extent in determining who might be dangerous, particularly before he commits an offense. Moreover, no traits, symptoms, or conditions which are useful predictors of dangerous behavior have been identified. Rubin, looking for such characteristics of danger, found that the literature was sparse, disorganized, and impressionistic. In summary, training and experience do not enable psychiatrists adequately to predict dangerous behavior. Rather, such predictions are determined by the time and place of diagnosis, the psychiatrist's personal bias, social pressures, the class and cultures of the respective parties, and other extraneous factors. Finally, even if psychiatrists could accurately determine which persons are mentally ill, that determination would not assist them in predicting dangerousness because, as has been previously noted, there is no correlation between mental illness and dangerous behavior. To the contrary, the mentally ill may even be less dangerous than the population as a whole. And next time I will pick back up at Part 3, Legal Consequences and Recommendations. I hope to see you there.